morning, everyone. My name is Jakub, and I am based in Dublin, on the other island, and I work for the Royal College of Surgeons in Ireland that is coordinating the South Africa project, which is a big consortium, international consortium involving European and African partners, working on scaling up safe surgery especially for district and rural populations in Africa. And let me tell you why did we pick surgery and district level. This is the background information in a nutshell. There's a Lancet Commission on Global Surgery formed recently, and they estimate that there's 5 billion people worldwide that don't have access to safe and affordable surgical care, and Africa is the continent is affected the most by this crisis. Surgical conditions account for about 11% of the global burden of disease, which is quite a lot, and conditions that are treatable with surgical care currently kill more than HIV, TB, and malaria diseases combined altogether. And why about that? This is about the surgical need, and the district level comes from the fact that 63% of population in sub-Saharan Africa lives in rural areas where district level hospitals are at the forefront of healthcare, and they're the main providers of healthcare services, including surgical care, or they're supposed to provide surgical care for district level population, for rural populations. And there's also a major crisis in terms of specialists. There is only around 1,700 surgeons for a combined population of 320 million people. That equates to around half of a surgeon per 100,000 population, which is, it's in the slide, 26 times less than in Ireland. The consequence of that is that district-level surgery is provided mainly by non-specialists, which means medical doctors or non-physician clinicians, which are people that have some medical background, but then they don't have a training at the level of physicians. And most of them, they don't have any formal training in surgery. So when they practice, they obviously need supervision, and they need supervision for various reasons, including the job satisfaction, including retention, including obviously quality of care. So we came up with a solution for the problem, and this is only one hole that we are trying to close with our Surge Africa project. And this is the concept of Surge Africa, which the column on the left represents the intervention, which is all about surgical supervision. We mobilize surgeons based at central hospitals, and we move them around 10 district hospitals surrounding each central hospital on a 3-monthly basis, providing supervision and mentoring and on-the-job training. We also build surgical teams. The specialist surgeons carry enough weight to set up the systems right at district level, working through district level officers and operating team members. And we also run some community sensitization activities to make sure that patients show up to these district hospitals, because some of them, they don't have a good reputation when it comes to surgical care. So people need to be aware that with the coming of the project, surgical care is being scaled up and it's safe. So the immediate outputs of the study, and these are our study endpoints, this is what we measure, is we are looking at enhanced surgical capacity on district level, various aspects. I won't get into details of that. And the primary endpoint of the study is the increased numbers and range of surgical procedures done at district hospitals. This is what we want to see: more surgical care provided at district level, and a wider range going beyond cesarean sections, simple fracture management. We also want to look at the responsiveness of communication and referral feedback system at district level. We want to connect district level with central hospitals using basically what people already do, which is to talk on WhatsApp. And then we have a WhatsApp group coordinator who manages the communication, and we have a data set that it comes together with it, that we look at and we measure certain things. That leads to we have already observed a decreased number of unnecessary referrals, cases that should have been kept at district level and operated at district level, and increased public awareness of surgical services availability at district level. Intermediate outcomes, obviously the improved surgical outcomes, increased cost effectiveness of deliveries of surgical care, reduced costs for patients, because patients, when they have a chance to be operated at district level, they don't need to travel long distances to central hospitals. We also look at not directly in qualitative way, but enhance job satisfaction of health staff, people when they're mentored, when they have someone who's looking after them and provides them advice and supervision and training, they feel more appreciated where they are, and that leads to increased motivation and retention. Improve utilization of district level hospitals, obviously, and better utilization of referral hospitals, because when cases are being kept at district level and the appropriate level of care is provided there, central hospitals can focus on the actual more complex surgical procedures when you need a specialist surgeon to operate on. And then long-term impacts: reduce morbidity or mortality, quality of life on a population level, improve functionality of the health system and access to care. Our scale-up strategy, because this is currently we're working in 31 districts in Malawi, Tanzania, and Zambia, and scale-up strategy, that the project, the aim, like when we designed the project, the big word was sustainability and scale-up. We didn't want to do anything that didn't have a chance of being sustainable or go beyond the lifetime of the project. So at the very early stage, we involved local partners in the design of the intervention, and that also was related to the fact that supervision of district-level clinicians is in the national health strategies in all countries. So we are not coming up with anything new. We are rather enabling certain things that the government, local governments want to happen using the project funds, and we are bringing lessons learned from the intervention done by the project feeding into the national scale that we hope that will happen under the leadership of local ministries. We also adopted the PAR, which is the Participatory Action Research, a very kind of a popular phrase, a catchphrase these days. That means that we meet our stakeholders on a regular basis. There's a high frequency of meetings at different levels with different stakeholders, including the district level clinicians themselves, which help to design the intervention. Because when we came up with our strategy, we thought that okay, this is what we want. But then when we gave it to the district level people, they said no. At our level, this is not exactly what we want. They told us, listen, in our hospitals we don't do fractures, so we need to get training in fractures. So why don't you adapt it and make it bespoke for every single hospital that takes part in the intervention? And we said, yeah, great, let's just do it. And then, as a professional association, initially we wanted to focus only on the ones who operate, on the ones who cut. But then other professional associations came on board and said, like, why don't you include anesthesiologists or anesthetists? Why don't you use operating theatre nurses? Why don't you use hospital managers? And we said, yeah, great, let's just do it. So we expanded from the original plan that included for supervision for surgeons only to a kind of a team supervision program. We also, we're very lucky to work with people that are keen to take on the ideas that we bring in, and that helped, especially in Zambia. I can bring the case of Zambia, because when we were discussing the rates, obviously this is work for supervising surgeons, so they need to be paid, and the people at the ministry, they were saying, no, there's no need for a discussion, because there's a government rate that we use, and you guys just don't go above that and it'll be fine, because that's the rate again. And the other point that we are developing as the project goes is that there's a wide range of costing studies to identify what are the financial mechanisms around surgery and how best to fund the supervision model. And what we find already is that there is, in every country that we work in, there is a budget line for supervision, but it gets diluted and it gets utilized for other different purposes. So what we want to show, what we want to demonstrate to the ministry is say, look, when you stick to the original plan of using this money for supervision, these are the benefits. Like if you every single referral or unnecessary referral is a cost for the system. So keeping patients at district level operating where they should be operated is a gain for the system. So we are coming up with a model that will demonstrate the effectiveness of this South African supervision. I think that's all. We work with the wide range of stakeholders at all levels, and I'd like to acknowledge all of them. Thank you.
Thank you very much for that. Thank you.